Hello, my name is Robert Thompson. I'm Executive Director of the NLMA. And in this video, I'd like to explain for you the new fee-for-service physician work disruption policy. It's a policy that we circulated on April 1st, and it's about income replacement during the pandemic period. What I want to do is walk down through each of the elements of the policy, but first say a few general words about the essence of how it's supposed to work. We really see four different pathways that physicians can use in relation to this policy. The first path is a physician who applies to be covered by the policy, and in so doing makes a commitment to be available to do additional pandemic-related services for the regional health authority. So if that's where you fit, you've examined the policy, you think that it's going to work for you, you apply, you make a commitment, and then the RHA will discuss with you the kinds of work that they may expect of you, and you go ahead and do that work. And then you benefit from the income guarantee associated with the policy. So that's the first path. Second path is where you decide that you don't want to apply for the policy. And if that's the case, and we'll discuss that more in a minute, but if you decide not to, you then can continue to bill for, of course, virtual care or in-person care to the extent that that's possible at this time. And then that's your income stream, and you'll carry on and really not have the policy having no direct impact on you. Another path is to not apply for the policy, but still nonetheless do or undertake. Tell the RHA that you're willing to undertake pandemic-related services, whether it be in an assessment center or an ER or some related work, and that you bill fee-for-service or sessional rates or fee-for-services according to the fee schedule for that work. And then, of course, you would bundle those billings with whatever other billings that you can do, virtual care or otherwise, and then that becomes your package of income. And you'll be able to come in and out of that work unrelated to the policy. So that path is available to you as well. The fourth path is to apply and then enter into a discussion with the RHA about the type of expectations they may have. And so there's nothing lost to apply, have that discussion. If you're not satisfied with the discussion, with the type of work they may expect you to do, you can just decline, and then at that point, and the policy will no longer be applicable to you then. But we are encouraging everyone to apply. So there's nothing lost in doing so. You gain the information about what the RHA may expect of you, and then you get to make that decision in a better informed way. Even physicians, and some have contacted us, that have their own concerns about availability. They may have their own immune issue. They may have special child care or parental care responsibilities. They may just uncertain in different ways. Those physicians should actually continue to, we recommend, apply and have the discussion with the RHA. There are some types of work that are less risky than others. And a lot of work is not risky. Some is. When I say risky, of course, what I mean is more directly related to management or support for care to COVID patients. But there are many other services as well within these all hands on deck, let's cover all the important services approach that the RHAs are taking. And so that's why we would encourage you to have that discussion with the RHA so that you can tell them about your circumstances. And if there's a match, great. There sometimes may not be a match. The RHA is trying to deliver services, so there are occasions when there won't be a match, and then you'll make your own decision as to whether or not the policy is good for you. So with that said, let me take you down through some of the key elements. Of course, this policy was founded on the same one that was in place in 2009 for the H1N1 event. So we had a starting place that served as a good platform to get a dialogue going with the government. And this policy applies to all fee-for-service physicians. And to be eligible for coverage under the policy, there's several criteria. You have to continue to carry out your normal services, so your normal practice to the extent possible, and that could be through virtual care or in person. Sorry, there's my phone. And it could be at your normal work site or an alternate location. So that deals with most contexts of physicians. So you have to, in other words, continue to attend to your normal practice to the extent that you possibly can. And then you have to also commit to be available to provide additional services during the pandemic. And we'll come back again to what those additional services may be, but the key is that you must commit to be available. Now, the commitment to be available will be followed up quickly with a discussion with the RHA about what availability means. But in terms of still the initial criteria to qualify for the policy, you need to provide information about your practice, what it was like prior to the pandemic, the settings that you operated in, full-time, part-time, whatever those characteristics were, and describe what's happened to your practice since the service reductions. The RHA wants to know, the gap, how it's changed, and so they can get some insight into your available time. And also if they impose perhaps upon your available time or even some of your normal time working, if they do that, they at least know they will understand your practice and they'll know what they're asking of you. It makes for better discussion. So you need to provide that kind of information. And then you also need to, if you're on an existing call group, you need to continue to participate in that. And there may be additional call groups that get formed during the pandemic. And committing to be available means committing to be available to participate on additional call groups as well. So if you agree to those conditions or criteria, then that will qualify you for an income guarantee of up to 80% of your last year's billings. Now, a few points to make about that. First of all, you have to continue to bill fee-for-service during the pandemic for your normal services and your normal patients and for the additional services that you provide. That will become your bundle of fee-for-service income. And then if there is a deficit in any pay period between that and the average of the last year, well, you'll be guaranteed a make-up payment up to 80% of that average of the last year. Now, how will the last year's average be calculated? Well, it'll be straightforward math for the most part if you work the full 26 pay periods. But if you had a significant interruption in the last 26 pay periods, a sabbatical, extended leave, other valid reason, you need to make that known to the department. And those processes haven't all been worked out, but there will be a clear process to make that request for the exclusion of those periods when your billings would have been below normal. Now, typical vacations or Christmas periods, those sorts of things, those are not excludable because they normally occur in every year. But it's the kind of things that would not normally occur every year, but did occur in the last 26 weeks. Those are the things we want to exclude. So that's how the 80% gets calculated. So then you're qualifying, and then the RHA will have a discussion with you about their expectations, the kinds of work, that additional services, what exists within that bucket of additional services. So the definition we have in our agreement is it'll include assessment centers, coverage in the ER, support to other clinical areas. The example came up today of support in chemotherapy, for example, which is not directly with COVID patients, but it's another critical service as other physicians within the RHA perhaps are moving around. And then, of course, there's the quarantine unit in St. John's has become known as the COVID unit. A lot of physicians in internal medicine are already participating in that. There are roles for other physicians in support roles. That will be no question of it being within the competency of physicians. in many of those places. If you're concerned about any role being within your competency, that's a discussion that you need to have with the RHA, because the commitment is that you will only be asked to undertake services that are within your competency. So that's the bucket of essential services. So the RHA will give you their expectations, and then they will ask you, and not everyone at the same time, no doubt, but you'll be asked to take on something. So once you agree to that assignment and you take it on, you fulfill the expectation, and you start work. You start, maybe it's 2 half days a week, maybe it's 4 days on, 4 days off. There could be many variations. That's when you start getting a guaranteed 100% of your last year's pay. So if you have a billing deficit less than 100%, you will get a supplementary payment that brings it up to 100%. I should note that the administrative processes are not all in place, and there will be a lag time as these calculations and formulas and payment mechanisms get put into place. The department has told us that it may take a month or more to get set to have the cash flow. So cash flow, no question, will be a delay, and that raises its own issues, which will have to be managed. So that's the 100%, the additional services, and the cash flow issue. So now a few other points before I end. A physician who ceases to be available, in other words, who has been available, provided some services perhaps, and then is no longer available, well, they have to notify the vice president in their region. And then, of course, if you're no longer available, then you step outside the policy. I think that's clear. If a physician, though, becomes ill with COVID-19, so if in the course of your duties in the additional services, or in the course of your normal services, providing insured services to your patients, or whatever setting where you're providing insured services, and you contract the virus, or you have your presumed COVID-19, or for some reason you need to self-isolate, well, all of those circumstances means, if they mean that you cannot provide services, it doesn't mean that you are bumped outside. What it means is that you'll be in this period of, let's call it an illness period. You will continue to be available or eligible for compensation up to the 80% level while you're ill or in isolation and can no longer provide services. Until such point as you become well and the RHA clears you for returning to be available to resume additional services. So if you return to be available and you continue your rota in providing additional services, you will start qualifying again for the 100% level. If your illness is extended, there is a limitation on the illness period for which the policy will still cover you, and that will be up to 90 days or whenever your disability insurance program will kick in. So the point there is that if it is an extended illness, you don't get dropped off into a setting where there is no income. And for most people, of course, hopefully all people, there will be a short duration, maybe 2 weeks, and then you're back into the rota. If you're ill for longer, you'll be maintained up to 90 days or whenever your disability insurance starts. If for some reason you become well, or when you are well, and if you choose no longer be available, again, you'll be stepping outside the policy, and the policy will no longer apply to you. There will be an agreement that you have to sign with the RHA, and it needs to be consistent with everything that I've reviewed now. So those are the key elements to the policy. I hope that you'll contact us and let us know if there are any questions you have, any concerns, any reasons why it doesn't apply to your circumstance, because we need that feedback so we can continue to provide input to the government. That's really important, and we'd like you to email us at nlma@nlma.nl.ca. That feedback is crucial. Some doctors have asked us as well about the issue of why doesn't this additional work pay just the same rate? There's a sense that there's some inequity, that we chose the ratio approach of 80% or 100%, which means that some doctors may be earning the same amount, or sorry, different amounts doing the same work. We had a long discussion at that at our board, very carefully walked through the issues involved and developed that option to compare it. But the board chose to move in a different direction, the one that you see now, based on several considerations. One was that this was rooted in the H1N1 policy, and so there was a platform to make rapid progress with the government. If we had jumped into a different approach, we would have had the complexity of developing the rate, but also developing something to cover the variable costs of overhead. And physicians have many, many different overhead costs. And so the complexity of all that meant delay. And so the decision was made to stay with this, which is an objective formula, even if though it may have some disparities. So that was the approach that we took, and we think it will work well for us, but we continue to want your feedback. So thank you very much for listening to this video, and we look forward to weeks of, I'm sure, stressful but productive work, and but also coverage by this policy, hopefully in a constructive way, and we look forward to hearing back from you. Thank you very much.